I'd like to introduce our next speaker, who's going to be talking to us about strategy for managing infections in combat injured personnel, which is a huge topic in Ukraine. And I want to welcome HAILIE UREN to give a talk on this topic. Welcome.
Thank you so much, everyone. And is the microphone okay? Okay. Excellent. Thank you for the invitation, and I'm really pleased that I'm able to speak about infections, because infections actually don't get a lot of publicity internationally. And why is that? It's not such a sexy topic. You can't really take a photo of it and put it in the media when people have such critical infections. It's not like a surgeon with a scalpel or a patient with a beautiful new prosthetic, but I think it is so critically important. And through my experience of the last 3 years working in Ukraine, you can go to pretty much any hospital in Ukraine, and every single person, even mostly the surgeons, will say, we need help mostly with the infections, which is why we really need to focus and be talking about this. So I don't know how many in the audience have been to Ukraine. Wow, Yabashotsu. I'm really surprised, because usually when I speak about Ukraine, people don't actually understand how large it is and also how diverse it is. I guess it's not as large as Australia, but it's as large as Texas, as Doug Davis keeps telling me to tell everyone. But let's go back, and what part of war? Because when we talk about war, a lot of the time people say it just goes hand in hand. Infections come with war. But does it have to? Does it have to? So when we think about the case of the Iraq and the Afghanistan war, and we think about such a highly financed, highly developed military as the US military, they started their infection prevention control programs back in the 70s, so they were very, very well established by the time the Iraq and the Afghanistan war began. Yet, from the casualties that got evacuated from Afghanistan and Iraq, the ones that had infections, 27% of those were multi-resistant infections. And we know that a lot of those infections were Acinetobacter baumannii. Now, if we move now to 2025, or I think it's 2022, the paper, 1% of all hospital infections are that Acinetobacter multi-drug resistant. So that's quite a significant amount of infections that have probably originated from those casualties evacuated from Afghanistan and Iraq. And how much does that cost America every year? Up to $1.6 billion. Now, we can change, we can decide whether Ukraine is part of the European Union, but we can't change the strategic location of Ukraine. Bacteria knows no boundaries. So when we say this cost of how much Acinetobacter or resistant Acinetobacter is costing the US, this cost will be from the Ukrainian infections, will be all over Europe in every hospital, if not beyond Europe. I know it's in the UK, if not beyond the UK into the US. So if we don't invest in helping the infections within Ukraine, this is going to be a significant cost. Let's put aside the casualties of Ukraine, which is why I've been in Ukraine for the 3 years. It's about the casualties and the Ukrainians, but it's a huge, huge cost and a significant implication on the future of this world. I know with COVID, a lot of people say, nobody warned us. You're all implicated in this now. I have warned you all. So don't you dare say nobody warned us about the infections coming out of Ukraine, because I'll get a list of all the participants here, And I will say all these people were warned. Now, it is actually really heavily documented in the media. And what I think is particularly interesting, if you look right in the middle, there's the headline, "Could a conflict-born superbug bring on our next pandemic?" That has been published by The Rolling Stone, a music magazine. If a music magazine is publishing on the infections in Ukraine, I can tell you from somebody who's worked in Ukraine for 3 years, we know about this, but there's been such little support coming internationally into Ukraine on this matter, which is a little scary. And what I have been doing, and why I have why I have these bags underneath my eyes, is to try and say the media is reporting on it. It's going to cost billions of dollars for the rest of the world in the future. It's costing thousands of lives of the Ukrainians. Please, let's come together and bring our support into Ukraine to help this situation. Now, why is Ukraine in this situation in the first place? It's not because the Ukrainians just don't care. Absolutely, they care. They all want help. But it's a difficult little situation that Ukraine has found themselves in. So in 2015, we know that Ukraine really has been on this journey to join the European Union. And part of that journey, the European Union has come to Ukraine and said, if you want to be part of us, you have to completely change the way that you're managing infection prevention control, antimicrobial stewardship, completely disband your previous Soviet epidemiological service and move over to our system. But that takes time, unfortunately. You would think that I've also been told I'm not allowed to talk about this, but oh well, I'm a bit rogue like that. You would think that you would then have the European Union, or in particular the WHO, supporting Ukraine during that transition period to move over quite quickly. It wasn't the case. There was 6 years from 2015 up to 2021 where Ukraine had nothing. Absolutely no infection prevention control, no monitoring of bacteria, nothing within the hospitals to help clean the hospitals, to track hospital-acquired infections. And then by the time that the Ministry of Health, who were trying to scramble and pull together all these new policies that aligned with the European Union, that was 6 months before the full-scale invasion. Of course, nobody was ready. And then now we have this situation where you have these tidal waves of casualties coming in with these awful war wounds, and you have these really new infection prevention control teams who were just not prepared. So it's a really difficult situation. USAID funding had been pledged back in 2015, and unfortunately, due to we couldn't predict that would no longer be available to Ukraine from 2024. We hoped that the WHO would support Ukraine in moving over to this new system, but only 300 people have been trained, despite their $112 million per year budget in Ukraine. But also what we need is, with these infection prevention control teams, we need nurses. We need nurses cleaning the patients. We need nurses cleaning the linen, changing the bedding, changing the dressings. We need the nurses changing the catheters. We have a nursing ratio in Ukraine of 1 nurse to 20 or 30 patients. Now, I am not a nurse, and I recommend the antibiotics. There are so many antibiotics that need to be given 3 times a day, but I know I can't tell a nurse to give them 3 times a day, because if there's 1 nurse per 30 patients, they can only give them 2 times a day. So it's just an impossible situation for the hospitals. It's really, it's such a struggle. But also, why would a nurse want to work in the hospitals when they're so underpaid? So they're all leaving the hospitals, and going into cosmetology or dentistry or these other industries, and that's why all the Ukrainian women are just so beautiful. But also these infection prevention control programs and antimicrobial stewardship programs, they take about 20 years to develop, and we're on year 4. They also have never been implemented during a war. Ukraine is the first one to try to do that. So Ukraine, huge respect to try to start this journey during the full-scale invasion, but let's be real, it's not working. We know the future of Ukraine needs infection prevention control. They need antimicrobial stewardship. That is undeniable, completely undeniable, but it needs also time to develop. So what are we going to do in the interim? We have a war, we have a crisis, and what I suggest is that we put in crisis interventions for this time, whilst we allow the system to develop organically, like the US system has had to develop, like the Australian system has had to develop. So I know a little bit about Ukraine. These are all the oblasts that I visited. Over half of the non-occupied, if you exclude the non-occupied oblasts, and I visited hospitals in every single one of these oblasts. And so I have a fair understanding of the trauma evacuation pathway. And each of the levels of the pathway, from the battlefield through to the very end of the pathway, has unique challenges at every point. So we really need to make sure it's tailored to each kind of area along the pathway, rather than just a one-size-fits-all, let's just implement one system across. But I can tell you what's happening at the end of the pathway, where I've spent the most time. So a hospital, as an example, so a casualty who's injured on the battlefield. I was speaking with Azov actually just this week, and previously they were getting casualties within 12 hours, which was pretty amazing. But even this year, on average, 5 days post-injury. Then they're evacuated, and they'll roughly pass through about 5 hospitals by the time they get through to their final destination hospital, which is where they'll get their reconstructive surgery or their burns treatments or their longer ICU stay. Now, what's happening in these final hospitals? Nearly 30% of the Klebsiella is completely resistant to everything. 20% of the Pseudomonas, completely resistant to everything. 40% of the Acinetobacter, resistant to everything. Now, on the right, considering most of you have been to Ukraine, I'm very pleased you can all read Cyrillic, but which I've had to do now. But we have this is a microbiology report. So what is more common than not is that we'll have casualties come in and they'll have 3 or more gram-negative infections, completely resistant to everything, completely resistant. Now, what can we do about these casualties? Well, if it's on a limb, we can amputate higher. And I know the US in particular has talked a lot about the amputations in Ukraine reaching World War I level. What they don't talk about, though, is about why. Yes, we had the tourniquet, I guess, challenge earlier in the war, but the Ukrainian military has been super proactive about changing their protocols, their training, and I know the US has supported Ukraine in changing the way that they're going about utilizing those tourniquets. But what we're seeing is that perhaps, for example, if we have a lot of the casualties who've stepped on a mine, or they'll have a lower limb amputation due to trauma, that casualty will have approximately, I think it's like a 45% chance of being able to mobilize again on a prosthetic. Now, that's not the case in Ukraine. What happens is that initial lower let's call it a below knee. I know that's not the technical term these days, but let's say that below knee traumatic amputation very quickly turns into osteomyelitis and then will turn into an upper leg amputation, if not above knee, the whole leg. Now, the chance of that person being able to mobilize or walk again, even with a prosthetic, is very, very low. So whilst, yes, we can be very quick and rush to amputate these infections, what is the cost to that human, or cost to the healthcare system long term, or cost to society where that person can no longer work anymore? So we have these fantastic surgeons who now actually probably are the world's best surgeons in war wounds, but unfortunately, the long-term cost to Ukraine is going to be significant due to these infections. Let's put limbs to the side. What happens if these bacteria were in the brain because it's been a penetrating injury to the skull? Or if the bacteria went to the lungs, or they had a blast injury to the abdomen and now it's peritonitis, or it's a urinary tract infection. Surgeons tell me, how can you amputate those? It's impossible. Unfortunately, that's the reality. And in the far west of Ukraine, we need to be very cognizant that it's only 70 kilometers from the border of the European Union. So I have to say, whilst we have sporadic interventions of very keen infectious disease doctors coming in, it's not enough. These bacteria are going to spread everywhere, and it is already all over the medical journals about how hard it is to treat Ukrainian casualties. So we've come up with a little idea. Now, these are the people that we have discussed with. I'm obviously the wallaby. But Ukraine is not treating this lightly. Ukraine is not ignoring this problem, not only because we are losing Ukrainians, but the Ukrainians who are getting treated for these infections are in the hospital for over a year. They're for over a year in the acute before they can even get to rehab. When we're talking about mental health, to be number one in a war, number two injured, and then to be stuck in a hospital for over a year, it's not really surprising we have mental health issues in Ukraine. So we have come together, a group of people who know a lot more about military medicine than me. I don't even know the difference between artillery and mortar and shelling. For me, it's just an explosion. But we've come together with a group of people who have decided we need to make a difference. We need to change, and we need to make a crisis intervention for our crisis environment. And now we need the support to be able to do this. So we have a very esteemed Dr. Berry sitting in the back, who is the co-lead of this project, and someone who has actual experience dealing with these war wounds in the past and can rapidly mobilize a military to make a change. So we have a lot of people from Ukraine. I was a little bit late, I was a little bit jet lagged today, but I'm not sure if you heard from Dr. Beshle. Then we have many Ukrainians. We have the Minister of Defense. We have the head of the whole Ukrainian military who's supporting this. The chief surgeon of the Ukrainian military wants this. We're all waiting and in anticipation to get this project started. So let me just tell you now a little bit of the project. So the first thing I did is I asked around. I said to Walter Reed Army Institute of Research, can you tell me what you know about the infections in Ukraine? And I am trying really hard not to be very facetious when I am talking about this conversation. They've been collecting intelligence from Ukraine since 2017. So they've been collecting data from Vinnytsia, from Dnipro, from Zaporizhia, and Kharkiv. And they made a very beautiful presentation saying, we figured it out. The problem is in Vinnytsia. Okay, cool, all right. And I said, okay, so, but like, you've been working with Ukraine for 8 years, so like, what have you done about it? They're like, oh, again, stop with the facetious. They said, you know what we should do? Bleach. Have we heard this bleach thing before? So they want the foaming bleach in the sinks. So then I went to the British military and I said, what do you know about this? They said, actually, for rare, they said it's purely hospital. It's purely hospital acquired, Hailey. Nothing to do with the environment. A lot of the internationals think there's so many different speculations where these infections are starting. And so I wanted to ask so many different people because I'm just a wallaby. So then I went to the British military and I said, what do you think? And they said, Hailey, actually, we've been collecting a lot of data from Crivery, and there is a lot of actual really resistant bacteria in the soil because a lot of the battlefield is previous farming lands and previous abattoirs, for example. And they said, don't listen to Walter Reed. And I was like, okay. And then I was thinking, okay, so then I went up to to Zhytomyr, and I was speaking to the chief of surgery there, and I said, tell me about your patients. And he said, Hailey, we get patients 5 days post-injury from Sumy. These patients have not passed through any major oblast. They come directly from Sumy to us 5 days post-injury. 90% of them have Klebsiella. And I'm just thinking, I wonder how Vinnytsia plays into this. So I think nobody really knows. And so what I'm proposing is we find out. We actually do this properly and we find out. So we know that within 5 days, just from Zaporizhia, just from Zhytomyr, we know we have 5 days to work with. So that it's the time starts now. We have 5 days. We have 5 days to keep these casualties clean. And then the surgical team needs to come in and needs to close these patients because we know a closed patient can't have an infection. So we have 5 days to keep them clean, and then the surgeons need to do their thing. But where is the problem starting? So we know the trauma evacuation pathway. What I suggest is we start even a little bit earlier. Let's go beyond the trauma pathway and actually go to the training camp. What percentage, and this again is this rumor, I love gossip. I'm never above gossip. Please always give me gossip. The gossip around the world is, but the Ukrainians have this already on them. That's the problem. Okay, sure. Why would they have them on them? Oh, because they've been buying antibiotics from pharmacies and self-dosing. Okay, sure. So let's break this down a little bit. So the Ukrainians, yes, there has been very relaxed legislation around buying antibiotics and self-dosing. However, we know that we can have resistance to moxifloxacin, levofloxacin, ciprofloxacin from self-dosing. We know we can have resistance to penicillins from self-dosing, particularly over COVID. We can't have resistance to carbapenems from self-dosing because they're not going to the pharmacy and buying meropenem and infusing it over 2 hours. And that's a completely different resistance mechanism. So I don't think that's the full picture, but I think we should start there. So what I propose, we test the microbiome of the casualties, of the Ukrainians. Nobody has ever done this before. The British military has told me, the US military have told me, nobody has ever tracked the microbiome across the trauma evacuation pathway, ever before. So this is groundbreaking research. If we know the microbiome, we can then anticipate what we should be giving prophylactically when they're injured and also in that role 2 environment. We also know the impact of the antibiotics. But we also know, I guess, the impact of the microbiome on these war-wounded infections. And then we change the guidelines. So as we were talking before, Ukraine has copied and pasted the TCCC, moxifloxacin and ertapenem, for pre-hospital antibiotics. I highly suspect there's a huge resistance to moxifloxacin. And ertapenem, we don't use in country. It's really expensive. So what they're doing is using ceftriaxone. And if we're using ceftriaxone, then that creates this environment in their body that is breeding resistance to these 3rd-generation cephalosporins, which then we need meropenem for, which then breeds this resistance to meropenem. So what I think is that we're going to have to change the TCCC. Call me audacious, but this is what I think we should do. So that's study 1. So we check the microbiome. This is my hypothesis. We need to change the antibiotics from the beginning. We don't have microbiology lab capacity early in the trauma evacuation pathway. So if we can predict what will work for these casualties, we will know what we could be using on the battlefield and also in the role 2. Groundbreaking. Then we have the contamination of the environment. Now, I originally didn't know this, but speaking with Azov, they've actually been tracking this. They've been fantastic, really interesting conversation. They told me that they have been swabbing everything. They've been swabbing patients, they've been swabbing the environment. Everything is resistant to cefazolin. You know what's super interesting? The latest update to the TCCC, the 2023 update, that has cefazolin as the prophylaxis. Awkward. Just saying. Then what we do, we change what is happening in the battlefield. So previously, for a wound, we assess it and we put it on a dressing. What we know, if they're taking up to 3 weeks to be transported from point of injury to role 2, we need them to do an initial irrigation of their gross contamination and apply an antiseptic. What antiseptic? These are open wounds. We don't know what works against the bacteria in Ukraine. We need to test this. So we get in the labs. I've got 4 microbiologists ready to do this. We need to know what can go straight into a wound to protect and to be an antiseptic for that wound, because that casualty may have a really long transition period from point of injury through to the role 2 environment. And then, so we've got the microbiome covered, we've got the initial injury covered, we're covering the external contamination. What's next? So this is an actual microbiology lab report from a sputum sample from the Lviv Military Hospital in early June 2025. 5 gram-negative bacteria in the lungs. Now, pneumonia is not a war wound. Where did these bacteria come from? My thoughts, it's come from the skin, contaminated medical equipment, and the hospitals that have come all throughout that pathway. But we can't treat that. We can't treat that pneumonia. So I pose this question. If the bacteria in Ukraine are no longer able to be treated with antibiotics, and the trajectory is the same as that if you were exposed to anthrax, if you're exposed to chemical warfare, nuclear warfare, radiological warfare, what makes the bacteria in Ukraine different to biological warfare? And then it got me thinking, why aren't we using some of the principles of biological warfare in Ukraine? It's very simple. It was when I was procrastinating one time. I love a good procrastination. So, for example, I know I am a yapper, but these are the chemicals used in Ukraine. The endpoint, if exposed enough, is due to pulmonary failure. Luckily, we haven't had radiological weapons being used, but if there was exposure, it would be acute radiological syndrome. The first thing that casualty would pick up would be pneumonia, and then they would die. And then obviously everyone was very scared about nuclear warfare and what would happen if they survived the initial blast, etc. Their immune system would absolutely crash. What would they pick up? Pneumonia. So how is that different to that sputum sample where we can't treat it with any antibiotics? It's the exact same trajectory. They're all the same symptoms. So if the endpoint is the same, shouldn't we be using these principles? So that's where we come to, which is my favorite intervention, and the one that we've been working on the most. We decontaminate. And why we need to do this is because we don't have the nurses in the hospital to clean these patients. Ideally, we have these nurses in the hospital who are cleaning the patients every day and changing the linen and making sure we have enough protein, but we don't. We just don't. We have a situation where we have our IPC team trying to learn how to keep the hospitals clean, but every single day, new contaminated patients are coming to crash on top of them. It's in this endless situation. So what we can do, remember we have 5 days to keep them clean. So pre-hospital, we decontaminate them with CBRN style, complete decontamination. We have done the tests for the antiseptic, so we now know what works against our bacteria as the cleaning agent. So when we have the casualties, we're presenting them into the hospital as clean. We know what prophylaxis they've been given because we've tested the microbiome. We know what bacteria it should protect against. And then they can go straight up. Something I didn't mention, 80% of war-wounded casualties go into civilian hospitals. So we know that then when they get mixed with the civilians, they're not cross-transmitting all these really deeply, deeply resistant bacteria. They can go straight on the operating table. The surgeon doesn't have to move away mud, which is what they're currently doing. And we know they're completely sterile. And as a nice little extra intervention, we bring the casualties into the care themselves. In Australia, we're all about person-centered care. We know the casualties are not getting enough protein. We know that they are not getting cleaned. Why don't we provide these little packs to these casualties? Why don't we engage some of these protein companies, chlorhexidine companies like HippocLens? Why don't we give them toothbrushes enough for 5 days worth so they're able to do some of this care themselves? And then they feel cared for. They're helping us care for them, and it's a happy little situation. But what I do know is that we no longer have drugs, so we have to say no more to drugs. So, дуже дякую.